At the outset, I would like to thank Dr. Kumar and other organizer for inviting me for this academic feast. So I will be talking on IO combination in first line, exploring new treatment avenues. The slides are provided to me by AstraZeneca, and I don't have any conflict of interest. So we know that almost 80% of lung cancer are diagnosed in metastatic stage, and they have a poor survival. With the advent of driver mutation and driver mutation driven therapies, in the last 10 years, the outcome of these subset of lung cancer have improved. But in cases of driver mutation negative cancer, there is still an unmet need, and chemotherapy IO combination has come up in a new way, and there have been new developments. And there have been various trials which have shown efficacy and safety of IO combination with chemotherapy in stage 4 non-small cell lung cancer. So if we see what is the rationale for combination of immunotherapy and chemotherapy combination, so chemotherapy provides rapid disease control in these patients. Also, chemotherapy causes cancer cell death and thus reduce tumor burden. This releases new antigens into the system which prime an immune response. The subsequent immune response requires the presence and activation of T cells, which can be done by a combination immunotherapy in these cases. So there have been studies and there have been combinations of different immune checkpoint inhibitors. So it has been seen that combining both CTLA-4 and anti-PD-L activity might have some complementary effect and might lead to some additional advantage when seen clinically. So as we see, so it has been seen that CTLA-4 therapies inhibit suppressive Tregs and T cell activity primarily in the lymph node. And when these activated T cells are migrated to tumor cell, the inhibition of anti-PD-L1 leads to activation of effector T cells and can complement the activity of CTLA-4, thus leading to a complementary action and can supplement the effect of CTLA-4 inhibitors. What is important to know that even this response is persistent even in the absence of continued therapy, and thus a short-term control of tumor can achieve a long-term survival benefits. That's the rationale based on which IO and chemotherapy combinations have been taken further into phase 3 trials. So this slide must have been discussed multiple times. What is to be highlighted that despite multiple driver mutation which have been identified in these patients, there still remains a subset around 30 to 35% which lack any driver mutation, and the outcomes has been dismal in this. And there has been resurgence of a lot of therapies, mainly combinations of IO as well as IO alone, which are driving the treatment landscape in this subset of patients. So this is a busy slide showing what are the treatment options which are available to us in a patient which lack a driver mutation. So these basically, the results are based on the PD-L1 status, which tell us the effect of immunotherapy in this patient. And I will not go into detail of this, but there are various approaches which have been used in each type of patient, including a immunotherapy monotherapy, a combination of immunotherapy and chemotherapy, a dual immunotherapy with Nivo plus EV. And there has been now interest in combination of the dual immunotherapy with chemotherapy with Nivo EP plus chemo, and further with durvalumab and chemotherapy in these type of patients. So this is just to highlight that with the explosion of treatment options, and there's still a lot of confusion in choosing the first line therapy in these type of patients. And as we can see, almost 15 therapies have a category 1 indication in NCCN, thus making the life difficult for us in clinics. So now coming up to Poseidon study. This was a phase 3 randomized open-label multi-center global study, which included treatment-naive patients with metastatic non-small cell lung cancer that lack an activating EGFR and ALK fusion. What I would like to highlight that these mutations were tested by using RT-PCR and IST, and no NGS was in these type of patients. These were further stratified based on the PD-L1 expression based on a tumor proportion score of more than or equal to 50, and whether their histology is squamous or non-squamous, as well as a disease stage. So almost 1,000 patients were randomized 1:1 to 3 groups, either a platinum-based chemotherapy group up to 6 cycles. The choice of chemotherapy is either a nab-paclitaxel plus carboplatin for both adenosquamous, a GEM-CIS for squamous, or a pemetrexed plus carboplatin for non-squamous cell carcinoma. The two other experimental arms were durvalumab plus chemotherapy, where durvalumab was given as 1500 mg every 3 weeks along with chemotherapy for 4 cycles. This was the induction phase. And the third arm, durvalumab 1500 mg was combined with tremelimumab 75 mg along with chemotherapy for 4 cycles. Those patients who had some response were taken up to maintenance, was given maintenance. In the chemotherapy arm, that maintenance was pemetrexed, mainly in the adenocarcinoma group. Whereas in those who was given durvalumab and chemotherapy, they were continued on durvalumab every 4 weekly, which was shifted from 3 weekly to 4 weekly. And pemetrexed was continued 3 weekly until disease progression. Whereas in the double IO group, durvalumab was continued 4 weekly and a single dose of tremelimumab. Only one more dose of tremelimumab was given at 16 weeks and was continued on pemetrexed and durvalumab until progression. So the primary endpoint of the study was PFS, which was assessed by independent central review, and the overall survival in the chemo versus a durvalumab plus chemotherapy arm. The secondary endpoints of the study was PFS and the OS in the dual immunotherapy plus chemotherapy versus the chemotherapy arm. They also wanted to study OS in patients with a tumor mutation burden more than equal to 20 mutation per MB in the chemotherapy versus the dual immunotherapy plus chemotherapy arm. Other second endpoints were objective response rate, duration of response, PFS at 12 months, best objective response rate, the quality of life, and safety and tolerability of the drug regimes in these patients. So if we come to the eligibility criteria, what I just want to highlight, they included patients with PFS performance status 0 or 1, which we now see in most of the trials, and most of these trials don't include patients with performance status 2. Secondly, what I wanted to highlight that, as I already told, that EGFR and ALK fusion testing were done not by NGS. They excluded patients with mixed histology and sarcoma or small cell carcinomas, and patients with symptomatic brain mets were also excluded. Only asymptomatic brain mets were taken in the study, and other exclusion criteria were as per the contraindication for immunotherapy, which we see in all immunotherapy trials. So if we look at the patient baseline characteristics, we can see that all the 3 groups were fairly matched with each other. So median age was around 63 to 64, which is what clinically we see in our clinics also. So there was a fair representation from various groups. So Asian population was almost 37%, but these were mostly East Asians, and most of those patients were not from Southeast Asia. If we see the squamous and non-squamous histology, almost 60% to 65% of patients were adenocarcinomas. What is important to see that almost 66% of patients had a tumor proportion score of more than 1%. Just one thing where I feel there has been some inequalities. So there are numerically higher number of patients with CNS and liver mets in the chemotherapy arm as compared to the chemoimmunotherapy arm. So if we come to the results of the study, so this is the interim results which were presented at World Cancer and Lung Congress last year, and the paper, the full paper has not yet been published. So if we look at the primary endpoint of the PFS in the Duva plus chemotherapy arm versus the chemotherapy arm, we can see that at 12 months period, the PFS improved from 13.1% to 24.4%. And we look at the hazard ratio, it is 0.74, and the confidence interval does not cross unity, and the p-value was significant. But when we look at the OS curves, the curves doesn't seem to separate much. And although numerically the OS was higher, but statistically the confidence interval crosses 1.02. So statistically there is no OS benefit with durvalumab addition in chemotherapy. Although this was an interim results, and the median follow-up for OS was 34.9 months, and for PFS the patient was followed up to 10.3 months. So if we look at the major secondary endpoints, when comparing the dual immunotherapy plus chemotherapy arm with the chemotherapy arm, as seen with durvalumab alone, the PFS at 1 year increased from 13.1 to 26.1, with the median PFS increasing from 4.8 to 6.2, which was also statistically significant with a hazard ratio of 0.72. But if we look at the OS in the combination immunotherapy plus chemotherapy arm versus chemotherapy, here it was statistically significantly better in the dual immunotherapy arm with a hazard ratio of 0.77, and a numerically increases from 11.8 0.7 months to 14 months. And if you can see, the curves are separating quite early at 12 weeks till when the chemotherapy was given. So if we look at a subgroup analysis, trying to understand why the benefit was there in the dual immunotherapy arm and the single immunotherapy arm doesn't have a benefit, we can see the benefit is mainly driven by the benefit which was achieved in adeno group in the dual immunotherapy arm, which didn't benefit as much in a durvalumab plus chemotherapy arm, as well as the benefit in the patient with even the tumor proportion score less than 1%, which is seen in dual immunotherapy arm, but not in those patients who were given single durvalumab. So if we look at the other secondary endpoints which were there, so we see the overall response rate was definitely higher in patients who received any kind of immunotherapy, whether it was a single immunotherapy or dual immunotherapy, with a significant increase from 24 to 38% in patients with durvalumab plus chemotherapy as compared to chemotherapy alone. What is important to look at, if we see that the median duration of response almost doubled from 5.1 months to 9.5 months in patients who were given durva plus tremi plus chemotherapy. And if we see that at 12 months, as compared to 21% patient, almost 50% of patients were progression-free in a dual immunotherapy plus chemotherapy arm, which was 40% in patient with durva plus chemo arm. So if we look at the pre-specified groups, stratified groups, so if we look at the outcomes in patients with non-squamous histology, we can see that the median PFS was numerically similar in patients with either given a single immunotherapy or dual immunotherapy plus chemotherapy arm, being 6.4 and 6.1, with a slight improvement from the chemotherapy arm. If we look at the hazard ratio was better for the immunotherapy plus chemotherapy as compared to chemotherapy arm. And if we look at the OS here also, the OS benefit was seen only in patients who were given dual immunotherapy, and the durvalumab plus chemotherapy arm doesn't seem to derive benefit even in adenocarcinoma group as compared to chemotherapy alone. So if we look at the squamous histology, in terms of both PFS and OS, that is clear from the curves we see, the outcomes didn't improve over chemotherapy alone in patients with either a single immunotherapy or dual immunotherapy arm, and there was no OS benefit or PFS benefit in the squamous histology. So if we look at the safety results are, there were no new safety signals which we found from this study. And the usual side effects, what we see in normal immunotherapy trials, the grade 3 or grade 4 adverse effects were fairly comparable between the chemotherapy as well as immunotherapy plus chemotherapy arms. If we look at even the treatment-related side effects, they were fairly comparable, and there was no new signal or new alarming side effect which came out of this study. Similarly, to this, the incidence of immune-mediated adverse effect were also comparable to any other immunotherapy trials, and there was no new or a specific side effect which is seen with a combination arm also. So if we put data into context for IO and IO trials, so we have two IO and IO trials which are available to us. One is the Checkmate 9LA trial, which combined Nivo plus EPP 2 cycles of chemotherapy, and the present Poseidon trial. So if we look at those, there was not much to choose between the two arms. The only difference was in Poseidon trial, 4 cycles of chemotherapy was allowed, which is what we use in clinical practice for patient, whereas in Checkmate arm, they gave 2 cycles of chemotherapy to reduce the tumor burden, then continued as Nivo plus EPO or the immunotherapy alone. And what is important to see that in both of the trials, crossover was not allowed. Crossover was not there in any of the trials. So if we look at a dosing schedule and what is difference between these two IO and IO trials, we can see that in Poseidon, we see in the induction phase, 4 cycles of durvalumab along with tremelimumab and chemotherapy was given. And then only 1 cycle more of tremelimumab was given at 16 weeks. And then only PD-L1 inhibitor durvalumab was continued and tremelimumab was discontinued. And PEM was optional, given to physician discretion. If we look at the Checkmate 9LA trial, we can see that Nivo and EPO both were continued until progression or 2 years, and the chemotherapy cycles were 2. What is the clinical significance of giving 2 versus 4 cycles? It is yet to be seen. So if we look at the comparison, although it's a cross-trial comparison, we cannot decipher much out of it. But what we see is even after combining two immunotherapies, the outcomes have not been what we would have expected, with a median OS of only 14 months in the Poseidon study, with even a dual immunotherapy plus chemotherapy combination, which is much lower than what we see with a pembro plus chemotherapy combination, reaching OS of around 20 months. Similarly, with the Checkmate trial, a combination of Nivo plus Epo plus chemotherapy gave a OS of almost around 15 months, which was updated 2-year follow-up, remained at around 15.8 months. What one thing is more important, that as compared to Nivo plus Epo, where almost 22% of patients discontinued treatment because of safety side effects, it was a little lesser, with around 15% in this combination of Durva plus Tremelimumab. So if we look at this, as we have seen in squamous histology also, there is nothing much to compare between these two trials, and the results are not as good as we would have expected. And the OS was pretty 10.4 months in the Poseidon trial, and in Checkmate it was around 14.5 months, which is what is seen in squamous cell histology with any immunotherapy combination which we have available. So the authors concluded that in the phase 3 Poseidon study, first-line Durva plus Tremelimumab plus chemotherapy improved PFS and OS versus chemotherapy alone. The PFS hazard ratio was 0.72 and the hazard ratio for OS was 0.77. And the survival was more prominent in patients with adenocarcinoma histology. So they proposed that it could be a potential treatment option for metastatic non-small cell lung cancer. So here at this World Congress on Lung Cancer, they will be presenting an exploratory analysis for OS outcomes in patients with STK11, KEAP1 and KRAS mutation, which we know are inherently resistant to all chemotherapy as well as immunotherapy. And it will be interesting to see if some of these combinations do good in these resistant subgroups. And recently we had the center which is long awaited open in Mullanpur, and we'll be happy to host you there for the next academic session. Thank you.